This week's program was filmed at Medical City, Dallas. Founded in 1974, Medical City is recognized for its state-of-the-art medical facilities and commitment to excellence in patient care. Located in Dallas, Texas, the hospital's medical team consists of more than 1,150 physicians, many of whom are recognized as the world's best in their specialties. Medical City, specialists in life. Welcome to Platforms, the life-lifting news program for women. Now, here's your host, Siobhan Palmer.
Hey, welcome back everybody to Platforms. I'm continuing my conversation today with Dr. Joseph Kuhn. Dr. Kuhn is one of the top bariatric surgeons in the state of Texas. Our topic today is the rate of obesity in the United States and some of these procedures that he and his team can offer to people to improve their lives. Dr. Kuhn, we've talked about gastric bypass, we've talked about lap band, and then there was a third procedure we talked about. Let's talk about the pros and cons of the sleeve procedure, and if you can just revisit how that procedure.
Okay. Just to reiterate, the sleeve is a procedure where we take the large, globular stomach, like a big balloon, and we turn it into a sleeve or a tube. It's more along the lines of the size of a banana. So you have a smaller pouch. It also removes the hunger-producing part of the stomach, which is in that outer stomach.
Wow. So
typically, the pros part of that surgery is that it does also work in most patients. So 95, 97% of patients at the end of a year will be happy, coming in, hugging us, and so it's rewarding in that sense. It works similar to a bypass at reducing hunger and not allowing you to eat very much. One of the benefits some people like are that there's no foreign body, so that they don't have to come in and get fills.
Oh, I see. Okay, like the band would be. Okay.
Another group of patients comments that they don't like the dumping syndrome associated with low sugars.
Now, what does that mean, dumping syndrome?
Well, we talked about with the bypass, sometimes if you eat sugars, it can make you feel jittery and lightheaded.
Okay.
And so technically, it's not that we want you eating a lot of sugars, but with the sleeve, you don't have that jittery feeling you get with eating some sugars. There's not as much reconstruction, so some patients have this mental picture that the sleeve is a simpler straight shot. You're not moving the small bowel around, and although from a surgical standpoint we don't really see it as being significantly different, but there are patients that have that perception that it's kind of simpler in that fashion.
I'm just trying to think from a visual standpoint, it's fascinating. So you go in laparoscopically and you've got a screen here, and when you're taking this globular, which I could describe my stomach as globular, when you're pushing, so there's no cutting away of any tissue, you're just literally pushing the pouch into the size of a banana and then stapling it with the titanium staples?
Well, in truth,
did I just ruin all your video?
No, you did good, but except for the fact we staple up alongside, but indeed that outer part of the stomach is discarded.
Oh, it is?
Yeah, so you have a permanently small tubular stomach.
So how do you discard that remaining?
It comes out one of the holes.
Okay. So it's kind of like a vacuum or something. All right. Well, after discussing these three procedures, each person's case is very unique. So how do you encourage your patients to decide which one of these procedures is going to work best for them?
Well, it falls into a couple of categories. So for example, I'm going to give you the patient that might be the perfect for a bypass.
Okay.
If it's a patient who has a lot of weight to lose, so let's say they're 200 pounds, 150 to 200 pounds overweight. They weigh 350, they're supposed to weigh 150.
Oh, wow.
That patient with a band will typically lose about 50% of their excess weight. So they may only lose 100 pounds.
Okay.
With a sleeve, they might lose 60% of their excess weight. With a bypass, they might lose 75 or 80%. So the heavier patient tends to do better with a bypass because they need to lose more weight. They're not going to be, they may lose 100 pounds, but they're not going to be happy, or they're not going to solve all their medical problems. So they may be 100 pounds lighter, but still be diabetic and have some of those conditions. So heavier patients, more bypass.
Gotcha. Okay.
Patients who are severe diabetics, the patients who are on insulin twice a day, with a bypass, they typically are cured within a matter of days. So they're off all their diabetic medication.
Really? Oh my God, that's remarkable.
Now, interestingly, the sleeve, we're seeing almost similar correction of diabetes rates. With the band, the correction or cure of an insulin-dependent diabetic is maybe only 20%.
Okay.
So if there's somebody who's on just 1 or 2 oral agents, we would still consider a band on them, and that may well get them off that oral agent. So diabetes is a big factor that would shift sometimes to somebody to a bypass or maybe to a sleeve.
Okay.
Reflux or gastric reflux is maybe the most important issue. And
Because that's miserable. Yeah.
it is
yeah.
miserable. If you have severe reflux and your esophagus is irritated, even precancerous changes, the only operation that really works good is the bypass, because the acid and bile no longer go up your esophagus. It's a cure in the recovery room.
The acid and bile that goes into the esophagus can cause cancer eventually if it's consistently irritating the...
That's correct.
Wow.
So if it's a person that has mild heartburn, like all of us do
Right.
after a late meal,
Right.
in that case, the band, for example, could be beneficial. So we're really talking about severe reflux that would shift a patient to a bypass.
Right.
So hearing those factors, the ideal band patient, somebody whose BMI is 35 to 45, they don't have a lot of weight to lose, they don't have severe diabetes, they don't have severe reflux,
Right.
and they're willing to come in and get the adjustments and fills. Somebody whose BMI is, again, 35 to 50, who don't want the inconvenience of a band, maybe they do have diabetes, but they don't have severe reflux, they might think more along the lines of a sleeve.
Of a sleeve. Okay.
And then somebody with severe reflux, severe weight, bad diabetes, think more along the lines of bypass.
Right.
And then the patient who, across that spectrum, is looking for an amount of weight loss that is sort of the largest amount of weight loss.
You have done so many of these procedures. What patient did you operate on that was the heaviest patient that you've ever performed any of these procedures on?
The heaviest patient has been a patient who was about 625 pounds.
625 pounds. You know, you and your team, could you share a story with us about a particular patient or patients that really touched you? Because these are life-changing for the positive, many of them surgeries. You're really redefining people's lives and,
I think some of the more rewarding are in operations. There's one patient I can think of who was 66 or 67, in a wheelchair, on oxygen, had previous heart attacks, bad diabetics, and seeing that patient within a matter of months, walking, off oxygen, free of diabetes, but I think it was at 6 months they'd already lost 90 pounds. And so
Wow.
the correction and transformation in that particular patient was amazing.
That's remarkable. Dr. Kuhn, hold that thought. We're going to go to break here for our last segment. When we come back, we will continue our conversation with Dr. Joseph Kuhn from Medical City, Dallas. He is one of the top bariatric surgeons, I'll get that right, in the state of Texas, and fascinating conversation today. This is Siobhan Palmer with Platforms, the life-lifting news program for women.